Hello, everyone, and thanks for joining us today. Welcome to this webinar on the impact of waste stigma and discrimination on patients' well-being in metabolic and bariatric surgery. I'm Dr. Eugenia Romano. I'm a research associate at the Institute of Psychiatry, Psychology, and Neuroscience at King's College London in the Department of Psychological Medicine. For those who don't know me, I work on the association between mental health and chronic conditions, and I have a PhD on the mental and physical impact of waste stigma. I'm also a member of the IFSO Education and Training Committee, and I would like to thank IFSO for the chance of organizing and chairing this webinar on this very essential topic. Waste stigma can profoundly affect not just physical and mental health, but also treatment outcomes for people living with obesity, and addressing it must remain a priority in healthcare setting. Hence, this opportunity to learn and discuss it together. I will thus introduce our speakers, moderators, and patient representatives who will join us in this conversation today. Just as a reminder, the webinar is recorded, and you can find the recording on the IFSO Virtual Academy and IFSO YouTube channel. If you have any question after the presentation, please type that in the question and answer chat box at the bottom of your screen. And also I want to thank Stephanie Darko for assisting us in the technical aspects of this webinar. So our speakers will be Professor Sanjeev Sokalingam, Scientific Director of Obesity Canada and Professor of Psychiatry at the University of Toronto, working at University Health Network, and Dr. Lisa Tulvanen, Registered Dietitian, Obesity Specialist at the Center for Obesity Academic Specialist Center, Stockholm Healthcare Services in Sweden, also postdoctoral researcher at the Department of Medicine, Huddinge, I hope I pronounced it right, at Karolinska Institute, and member of the IFSO European Chapter Integrated Health Committee, as well as of the IFSO Scientific Committee. As for patient representatives, we will have Mary Metcalf. She was having some technical issues in case. She represents the European Coalition for People Living with Obesity, also known as ECPO, and she's the first chair of the Norwegian Association for People Living with Obesity. I would also like to mention Ken Clare, another member of ECPO who was meant to join us today in this webinar, but sadly couldn't because he was not feeling very well. And as for the moderators, we have Professor Itka Graham, head of the Helen McArdle Nursing and Care Research Institute, professor of Health Services Research at the University of Sunderland, honorary lead for Health Services Research at South Tyneside and Sunderland NHS Trust, and chair of IFSO Integrated Health Professional Guideline Committee, and Andrea Schroeder, who is a registered nurse director of Taylor Clinics, private medical and metabolic bariatric surgery practice in New Zealand, also member of the Australian New Zealand Metabolic and Obesity Surgery Society, and current president of IFSO Integrated Health Section. And I would like to specifically thank anyone who's joining from very different timelines, because I know it can be tricky with this kind of events. But I would like to start with passing the word to Professor Sokalingam, and his presentation will be Breaking Barriers, Addressing the Nexus of Stigma and Mental Health in Metabolic and Bariatric Surgery. And after the presentation, we will have 15 minutes for discussion and questions.
Hi, I'm Dr. Sanjeev Sokalingam, and it's a pleasure to be here to be presenting on this IFSO panel on stigma and its relationship to obesity and metabolic and bariatric surgery. My presentation will focus on breaking barriers, addressing the nexus of stigma and mental health in metabolic and bariatric surgery. I work as a psychiatrist, but also obesity medicine specialist, and I'm from Toronto, Canada. I'd like to start off with some disclosures. I have no conflicts of interest related to this presentation. I hold a position as Scientific Director for Obesity Canada and work and care for individuals living with obesity in my clinical practice. And I also conduct research from these funding sources related to psychosocial aspects of metabolic and bariatric surgery. But I'd like to begin by a reflection, just asking you to think about a patient or someone you know who has been living with obesity since their childhood. They are now seeking help as an adult. Let's say they're in their mid-30s for weight loss. And they report a history of depression, anxiety, and a long-standing history during their childhood of weight-based bullying. And I'd like for you to think about what might be the relationship between those early experiences of weight bias, stigma, which started in childhood but likely was perpetuated through their healthcare experiences and experiences in society, and their relationship with their mental health. What might have led to some of the mental health presentations in their adult life? And keeping that in mind, how would this impact your treatment approach with this patient? I'd like for you to hold those thoughts for a moment and then think about some of these questions as I share a little bit about some of the research experiences and opportunities for us to improve and reduce weight stigmas and bias within society and in healthcare. So as I mentioned and as highlighted in this case, weight stigma and bias is pervasive, and often for people throughout their lifetime who might be presenting as adults living with obesity, many of these experiences have started during early childhood. This is data that came from a large database from Weight Watchers, WW, from multiple countries, looking at the frequency of weight stigmatizing experiences and seeing where their onset may be. And you can see that there's a lot of front loading, a lot of early experiences related to weight bias and stigma that happen for many of the patients in this database. And again, one of the things I will highlight that although I might be focusing on adults living with obesity, this really has to focus on how do we support children and youth and empower families in terms of addressing this issue, specifically as it relates to the impacts and sequelae related to mental health. And what are those mental health complications? Well, weight bias and stigma impacts a myriad of areas related to formal mental health diagnoses, but also mental health and well-being. There are numerous longitudinal studies, cross-sectional studies that have shown that weight bias and stigma increase the rates of depression, especially internalized weight bias, increase the rates of anxiety, things like social anxiety, but also anxiety in general and anxiety symptoms. We also know there's a close link between internalized weight bias and negative sense of self or poor body image and low self-esteem. There are also data that has shown that people who have strong internalized weight bias and experience stigma over the course of a lifetime having increasing frequency of suicidal thoughts or suicidality. The most robust data is actually on weight bias and stigma as it relates to internalized weight bias being correlated with higher rates of binge eating, emotional eating, and other types of disordered eating, including symptoms of food addiction, for example. And then lastly, there are some studies and associations about substance use, and again, other addictions that might actually manifest as a result of internalized weight bias. So again, thinking about this when we are seeing individuals who might be presenting in clinics in a range of healthcare settings who have endured negative experience as a result of their weight and internalize that weight bias, this can lead to a predisposition and a vulnerability and also presentations on all a range of mental health and addictions issues. If we look a little closer at PTSD or post-traumatic stress disorder symptoms, we can think about the hypothesis that weight stigma and internalized weight stigma might be linked closely to traumatic experiences and therefore might heavily influence post-traumatic stress disorder symptoms. And this cross-sectional study published a few years ago looking at patients presenting for metabolic and bariatric surgery looked at adverse childhood experiences or ACEs, which we now know are associated long-term with increased mental health complications and physical health complications. PTSD symptoms, internalized weight stigma, and weight stigma as a whole. And what they found is that weight stigma, and specifically internalized weight stigma, together accounted for about a quarter of the variance in their model in terms of the presentation of PTSD symptoms. And this was after accounting for the influence of demographics, so age, sex, ACEs, so adverse childhood experiences, depression and anxiety symptoms, and even the experience of an identified traumatic event. So really, you can see that weight stigma really at a systemic and individual level needs to be addressed if we are really going to address PTSD underlying symptoms and their presentations. Internalized weight bias is also associated with disordered eating pre and post metabolic bariatric surgery. This is a longitudinal study that our lab conducted looking at patients pre-surgery, 6 months post-metabolic and bariatric surgery, and 12 months post. And what it showed is that internalized weight bias was significantly associated with binge eating and emotional eating across all 3 time points. And although that this association decreased over time post-metabolic and bariatric surgery, it still persisted at 12 months post. And so again, if we don't address and support our patients in terms of weight bias, it can start to interfere with patients' weight loss journey and obesity treatment in terms of metabolic and bariatric surgery. And so again, this is why it's so important for us to address early on. So what are the interventions to address weight stigma and the effects on mental health? Well, I think let's start at the system and provider level. We often gravitate towards the individual, but really it's a responsibility as a society and as a healthcare provider for us to unlearn and relearn. And we need to do this early. And so we've done some work looking at the evidence for obesity education interventions for current and prospective medical professionals. And although there's a lot that focuses on communication, being aware of obesity and obesity causes as well as treatments, not a lot of research has been done studying how we can teach and support people to relearn obesity science and address weight bias and stigma in 2025. And so as a result of that, there's a need for those kinds of education interventions. In addition, it's really important for us to start early, whether it's medical school, being a physician, or other healthcare providers in that undergraduate setting, to train in integrated approaches to addressing weight bias and stigma in curricula. And so we identified competencies, and one of those core competencies is to address weight bias and stigma, being aware of it. How do we consider it in our environments and our communications with patients as well? And so really, we should be developing curriculum and standards for teaching obesity nutrition, focusing on weight bias and stigma. And at the individual provider level, it's so important for us to be cognizant of the impacts of weight bias and stigma. If a patient living with obesity presents, our attitudes, whether unconscious or conscious, can sometimes enact or perpetuate pre-existing biases that might lead to stigma, and those can lead to patient avoidance in care, increased stress, mistrust of providers, challenges with adherence because of a lack of trust, poor communication difficulties. And our stereotypes unconsciously may make us biased to certain decision-making. We may not offer certain treatments to patients living with obesity, whether it's related to their medical care or mental health care. And all of this can have negative impacts on patient outcomes. So it's so important for us to think about our communication approach, empathy, and engaging patients in care. I will say one thing, that stress, for sure, from stigmatizing behavior can lead to biological changes that can increase cortisol response, which also leads to potential mood and anxiety changes as well. And this is part of the biology that might predispose people to these stress responses and these kind of traumatic experiences, unmasking mental health complications in patients. So what can we do for individual interventions for weight bias and internalized weight bias? Well, there are three things that might be helpful based on the literature. Cognitive behavioral therapy, which looks at feeling, thoughts, and behaviors, and really examining more specifically those automatic thoughts or thought traps that people experience that are fueled by underlying core beliefs, often as a result of years of negative experiences as a result of weight bias, right? Being told that someone might be too lazy or not good enough, directly or indirectly through healthcare experiences or their interactions in their social lives. And so CBT is one intervention. Acceptance commitment based therapy is another type of intervention that uses mindfulness to notice judgmental thoughts without acting on them, and really aligns with patients' values and using that to distance from negative self-talk. And then there is some data on self-compassion approaches in a psychological sense, that really shifting from self-criticism to self-reflection, using guided meditations. There's mindfulness meditation, loving kindness, compassion letters, positive affirmations, and so on, to really address some of those negative self-talk that might occur, or self-criticism, in a way that really is more appreciative and reflective in nature, really to combat that internalized societal bias. We, speaking about cognitive behavioral therapy, our team has come up with a 7-session intervention that's evolved over the last 10 years. And I will say within that, cognitive restructuring has been a real key component to addressing some of those negative thoughts, specifically, the thoughts of I'm not being able to lose enough weight, or I'm a failure. So that's the all or nothing thinking, or labeling I am lazy, for example. These are the inner thoughts that have been embedded and internalized from years of stigmatizing behavior as a result of weight bias. And so through cognitive behavioral therapy, this is from a paper where we interviewed people who went through one of our clinical trials, that patients can learn maybe not to judge themselves, as that distancing, being aware of those cognitions and thought traps. And you read in this quote here from a patient that, they come to realization of how judgmental they've been about themselves based on how others have viewed or talked about them as well. And it really creates this distancing and self-confidence. And then lastly, I just will say that, the effectiveness of CBT, and this is a virtual CBT from one of our multi-site randomized controlled trials, has resulted, as shifting some of those cognitions, in addition to the behavioral components, in improvements in depression, anxiety, and disordered eating after metabolic and bariatric surgery. This was delivered 1 year post-surgery and was a 3-month intervention. It showed persistent improvements in all 3 domains for the first 3 months after just 7 sessions. And the emotional eating benefits actually were maintained for 12 months post-intervention without boosters. Booster sessions might be helpful to really enhance those skills for patients, particularly those reflections as those negative thoughts and schemas may crop up again as it relates to that inner narrative of weight bias that has been so pre-programmed and ingrained in patients, unfortunately, as a result of societal and healthcare impact. So again, targeting that through 7 sessions, but also supporting patients longitudinally with these boosters can be very helpful. So in summary, I hope this has provided the link that there is a nexus between weight bias and internalized weight bias, with a myriad of negative mental health, self-esteem, body image, and poor quality of life effects. It's important that we don't just start on individuals and supporting them as the sole intervention. We need a system and societal change, and also need to inoculate our providers with better information on and awareness about their own weight biases, and really unlearning and relearning how to address weight bias with more compassionate communication and understanding. And again, there are effective psychological interventions that can be helpful, and we need to increase access and study their efficacy, especially in the context of metabolic and bariatric surgery, but in an obesity treatment overall. So I'd like to thank you again, and these are some of the weight bias and stigma basics and tools that we offer through Obesity Canada. It's free access, and feel free to scan those. There's a more intense program that can help as well, including how do we think about our environments and our words as well to make them less stigmatizing. And we have a podcast as well that talks about obesity management that is co-produced by a person with lived experience and a healthcare provider. And every segment or every episode has a stigma reflection and busting component. So really an important piece to integrate as part of all our teaching and learning. Thank you again.
Thank you for the presentation. As a psychologist, it was truly appreciated. I think I would love to start the conversation after this with Marimet's comment as a patient representative, and Andrea and Itka can also lead conversation. We already have one question from the chat box as well. So if Marimet wants to introduce her perspective on the matter, it'd be great.
Thank you so much. When listening to this lecture, I was thrown back in time. I had my gastric bypass back in 2012. What really caught my attention the most is the risk of keeping up the disturbed relationship with food, because we have this tendency to use food as a regulator, either to enhance or lower our emotions. And even though we do something in our stomach, we don't do something in the head. So we do need support to be able to have a healthier relationship both to food, but most of all to ourselves, because we are taught that the numbers of the scales tell something about our value, but it doesn't.
Absolutely. I think that's the probably most frustrating part of the whole deal when it comes to obesity. Like, food is something that should be so natural. It's a resource we all need. And when something so natural is perceived and experienced with such negative emotions, there's truly something that needs to be fixed and addressed. I think Itka wanted to share a comment here.
Yeah, I was just going to say we've had a question, but I suggest we have Lisa's talk and then we have questions at the end. But we've saved the question on Sanjeev's talk, and we will have a question and answer session, answer the questions after the second talk, just in the interest of time, if that's okay.
Absolutely. No. So it's even a richer discussion at the end with both presentations, I think. So I would say let's introduce Lisa's presentation. The title is Persisting with Stigma, Experiences Across the Metabolic and Bariatric Surgery Journey.
Thank you so much for the opportunity to speak in this webinar. My name is Liisa Tolvanen, and I am a researcher and specialist dietitian in obesity management based in Stockholm. I am going to talk about persisting weight stigma, experiences across the metabolic bariatric surgery journey. When we think about patients aiming for metabolic bariatric surgery, it's easy to imagine their journey starting the day they meet the metabolic bariatric team. But for most, the journey begins long before that first appointment. Every patient's experience is, of course, unique, but many have lived for years navigating weight stigma, feeling misunderstood or unfairly evaluated because of their body size. Some may have avoided healthcare for fear of not being taken seriously, while others have faced repeated negative experiences in clinics, workplaces, or social settings. As healthcare providers, our role is not only to focus on the surgery itself, but to understand this broader journey. That means we need to listen to patients' experiences without assumptions, show empathy, acknowledging the challenges and emotions they carry, and validate their feelings, making clear that they are seen and respected. Recognizing the emotional and social landscape that precedes the first visit is essential to providing care that truly supports the whole person. This understanding is the foundation of patient-centered care. One of the most striking patterns we see in obesity care is the significant delay between the onset of weight-related challenges and the moment when individuals seek medical support. On average, people wait 6 years before engaging with the healthcare system about their weight. And this delay is not simply a matter of time. It represents years of frustration and often unexpressed concerns that could otherwise be alleviated through earlier intervention. During this period, most individuals rely heavily on self-directed weight loss attempts. They cycle through a wide range of diets and exercise regimes. Many invest enormous energy, time, and financial resources into efforts that are often unsustainable or insufficient for managing a chronic, biologically driven disease. These repeated attempts can create a sense of personal failure when the weight inevitably returns, reinforcing the belief that they must try harder rather than seek medical support. It's important to recognize that these efforts reflect significant personal determination and resilience. People living with obesity routinely demonstrate incredible persistence. They try again and again and again, often with limited guidance and little acknowledgement of the complexity of obesity as a chronic metabolic condition. Their persistence is not the problem. The problem is that they are attempting to manage a disease, often alone, that rarely responds to willpower-based strategies alone. The 6-year delay represents lost opportunities for earlier intervention, worsening metabolic health, and reduced quality of life. To encourage earlier engagement in care, we must understand that emotional and social factors contribute to this hesitation. Accessing metabolic bariatric surgery presents several challenges for patients with obesity, and experiences of stigma play a significant role in limiting the use of this evidence-based treatment. Weight stigma, particularly within healthcare settings, can discourage individuals from seeking surgical care. Concerns about being misunderstood or not fully heard can lead some patients to delay or avoid conversations about surgery. Internalized stigma further compounds this issue. When patients absorb negative societal beliefs about obesity, they might doubt their eligibility for surgery or minimize the seriousness of their own condition. This self-doubt can delay or even prevent them from pursuing an intervention that could meaningfully improve their health and quality of life. This brings us to one of the most persistent challenges in obesity care, the profound underutilization of metabolic bariatric surgery. Despite overwhelming evidence supporting its safety, efficacy, and long-term benefits, millions of patients meet established criteria for metabolic bariatric surgery, yet only a small fraction is ever referred for surgical evaluation, and an even smaller number ultimately undergo surgery. The result is that countless individuals miss out on a treatment capable of improving metabolic health, reducing medication burden, putting type 2 diabetes into remission, and extending life expectancy. Understanding why this gap exists is essential if we are to improve outcomes and build a more effective, evidence-based system of obesity care. Misinformation, stigma, outdated beliefs about safety, and a persistent last resort thoughts all contribute to a culture in which surgery is offered late, often after years of disease progression and suboptimal attempts at non-evidence-based methods. Our task as clinicians, educators, and advocates is to shift this mindset. Metabolic bariatric surgery is not the end of the road. It's a powerful, proven metabolic therapy that should be considered in appropriate patients, not withheld as a final option. When we meet patients who are preparing for metabolic bariatric surgery, it's important to remember that many come with deep hopes for change and health improvements. Many imagine that surgery will transform not only their weight, but also how they feel about themselves, their relationships, and their daily lives. And these expectations are completely reasonable. They often come from years of lived experiences and a desire to feel better both physically and emotionally. At the same time, research shows that it's common for expectations to become high, particularly regarding psychological well-being and changes in health-related behaviors. Many hope that surgery will make it easier to adopt new eating habits and increase physical activity, something that is understandable given how challenging these changes can be prior to surgery. While surgery can provide important support, these adjustments still benefit from continued guidance, follow-up, and time. If reality looks different than expected, patients may feel discouraged or even blame themselves, even when the surgery has provided optimal outcomes. This is why it's so important that we take time to explore each person's hopes, concerns, and questions before surgery to lay the foundation for a positive and sustainable long-term outcomes. Weight stigma often persists even after surgery, regardless of weight loss. Patients may feel judged if their weight loss is slower than expected, less than hoped for, or they experience recurrent weight gain, rapid weight changes, or challenges with dietary adherence. Concerns about how healthcare providers, family, or peers might respond can lead some individuals to miss appointments, share less about their challenges, or hesitate to seek support. Follow-up care is a critical component of metabolic bariatric surgery. It supports optimal outcomes, monitors for potential complications, and reinforces health-related behaviors over the long term. However, weight stigma can affect follow-up by influencing both how care is offered and how it is received. Healthcare providers may unconsciously assume that patients with obesity are non-adherent, unmotivated, or personally responsible for their health outcomes. This bias can result in less proactive care, such as fewer follow-up appointments or less comprehensive counseling. Patients in turn may experience frustration or self-doubt regarding their weight outcomes or perceive that surgery as a personal failure, leading them to avoid follow-up care to escape perceived judgment. Recurrent weight gain after metabolic bariatric surgery is common, expected also to some degree, and influenced by several factors. Yet the experience of recurrent weight gain is often compounded by stigma, which can profoundly affect patients' emotional well-being and engagement with care. Patients may worry about others' perceptions if they experience weight changes. Comments implying lack of effort can increase feelings of shame. Perceived criticism or assumptions of failure can be disheartening and reduce engagement with follow-up care. Social narratives often frame recurrent weight gain as a moral failing rather than a biologically influenced outcome. Internalized stigma can be equally damaging. Patients may blame themselves, feel guilt, or experience low self-esteem, which can lead to avoidance of medical appointments reluctance to discuss challenges, or discontinuation of supportive behaviors like dietary monitoring, physical activity, or psychological counseling. This cycle of shame and avoidance can further worsen outcomes. Stigma surrounding recurrent weight gain also interacts with mental health and may reduce the adherence to follow-up care, which in turn can contribute to further weight gain. Every patient's needs are unique, so it's important to get to know each patient and what kind of support would be helpful. Creating a size-inclusive environment starts with a welcoming spaces and equipment that accommodate all sizes. When meeting a patient, focus first on what matters most to them. Asking, "Is there anything specific you'd like to discuss today?" shows respect for their priorities. Conversations about weight, thoughts about obesity treatments or outcomes should be sensitive and permission-based. Use person-centered language, validate experiences with weight stigma, and acknowledge that weight and health are influenced by many factors. Shift the focus from weight alone to overall health, health-related behaviors, and recovery. Ask questions related to patient surgery, such as, "What challenges have you experienced with your recovery?" or changes related to your health goals. "What support do you feel would help you at this stage?" Engage in shared decision-making, explore support and treatment options, and set realistic goals, always respecting the patient's choices. Finally, acknowledge progress and validate challenges. A welcoming, compassionate, and respectful approach helps every patient feel seen, heard, and supported throughout their surgical journey. Stigma is a persistent and multifaceted barrier that patients face before, during, and after metabolic bariatric surgery. It affects access to care, decision-making, adherence, and long-term outcomes. Stigma is not just a social issue, it is a clinical barrier. There is no such thing as simple success or failure in obesity management. Obesity is a chronic, progressive, and often relapsing disease. Because of this, weight management is not a one-time project with a clear finish line. Instead, it is an ongoing process that requires long-term strategies, support, and adjustment over time. Addressing stigma requires awareness, empathy, and a multidisciplinary patient-centered approach. Recognizing and addressing stigma throughout the metabolic bariatric journey is essential to transform care from a cycle of shame and delay into a pathway of support, empowerment, and lasting health improvement. Thank you.
Thank you so much, Lisa, for your talk. We already have some questions in the chat box about how medical treatment might affect the impact of stigma in the future. But again, I would like to start the discussion with Matt's comment as a patient representative. So what do you think of these presentations? What's your perspective on these topics?
When we search help and ask for weight management and better health, we have this long history of defeats. We do believe that we are the one to blame, and we've been taught and told that obesity is a behavior. So having the right support throughout the journey and not focus on this performance approach, but shift from weight to health is important so that we come back and ask for help and support when we need it.
Absolutely. And Itka and Andrea, would you like to mention the questions we have in the group chat? Because I think they're very interesting.
Yes, yep. Well, just here, I think the first question we had was for Sanjay, and it said, "Is there any study or in your personal experience where in a slow or stuck weight loss of a patient has started to move in a positive direction after CBT?"
It's a great question because in many of the studies, including ours long term, um, if we stick at weight, focused on weight loss as the primary target, the data is not that great actually for CBT alone, just for weight loss, because many of the other interventions like surgery or medications tend to have pretty profound effects on weight loss. But where CBT and psychological interventions, particularly to address weight bias, to address, a range of things, behaviors and weight bias as well, I would say the benefits are really about reducing things that Mary Matty talked about, which are, relationship with food long term, or disordered eating, or mood or anxiety challenges. And if we know those things interfere with weight maintenance, but more importantly, health and well-being for patients. And so I think that's where the benefit is. But Mary Matty, maybe you want to comment further on that as well.
Thank you. Yes, if we do have this disturbed relationship to food and don't get any help for it, the risk of substituting food with alcohol, drugs, money, sex, whatever, is rising, and that's not good for us. So yeah, we do need psychological support.
There's a couple of questions in the group chat which they're very similar, and I think they're very interesting to discuss because they both mention how access to medication and new drugs will change the impact of stigma on patients' perspective. Personally, from my own studies, I'm thinking that's true. It's gonna be something to look at. It's very interesting, but I also think even with patients with cancer, some of them still feel guilty for their condition because of the behavior they had in the past. And even if there's treatment and if there's evidence that, it can happen to anyone, there's still this pervasive shame about it. So what in the case of obesity, what do you think how this would change with medications? Would this change? What is your opinion on that?
Maybe Mary Matty, do you want to start first? I can, and then Lisa, you can go second. I'll go last. How about that?
Yeah. At least in Norway, we do see that the medications has led to increasing the stigma because you no longer have an excuse to have a larger body because now the medications are there. Why don't you use them?
That's very interesting from a patient's perspective. Yes, absolutely. And Lisa, Sanjeev,
Yeah.
anyone else, if you
Yes,
want to comment?
I can comment. Thank you. Was very, very interesting question, and we don't really know yet what happens with the stigma when we have more broader access to these medications. Now we have, as Mari Mette, you said that we have this question about that not everybody are able to use these medications yet because they are too expensive. That's the very I think there is also a stigma in this question that they are not affordable for everybody yet.
Yeah, I'd add to build on both those comments just to say I think the effects on stigma are in my experience clinically in speaking with patients. Again, I think the research is coming out that there are benefits, but also still longstanding kind of stigma related to this. And the benefits are there's hope and there's another tool in our toolbox to use for obesity treatment, and a dialogue about obesity as a chronic disease and the brain science and the physiology, and those discussions increase when we have more treatments available and have those discussions with patients. I think the things that I've also heard from patients, and I think some early studies are showing, is that people still are seeing what happened with metabolic and bariatric surgery. You lose, uh, weight, but, gain health, but people focus on the weight loss and say you took the easy way out by taking these medications, right? Just like we've heard for decades with surgery, right? You took the easy way out by taking and getting surgery, which we all know is false. This is very hard work in any of these treatments, but that's the perception in society. And I'll just say for Lisa's comment, I do think there's a systemic bias in terms of access to medications because in my country, if your hemoglobin A1C is a certain percentage, you can get access to these treatments through our universal kind of drug coverage or programs in different provinces. But if you have other health issues related to obesity, you will not get access to those treatments, right? And so why would that be? And if I take your cancer analogy, Eugenia, I would say, what would we say in terms of people who could get life-saving treatment for cancer, which are often quite costly, but governments usually cover them. But for obesity, governments do not. So there's inherently some systemic bias of how we see obesity. I realize there's economics, but sometimes we don't ask about other chronic diseases as well, right?
Speaking of, there's a question in the box that a comment that's very strongly related to what you just said, that there is a challenge in how resources can be limited and not accessible to everyone. So some people might not even be aware that there are some resources for patients. And I think that's where governments need to take a step. Italy, for example, just recognized obesity as a chronic condition, lawfully speaking. And, when it comes from the top, it shapes the perception in the society and what are the rights of patients, because health is a universal right and it should be always dealt as such. And Itka, you have your hand up as well.
Yeah. I just want to make a comment. We're going back to about the stigma in relation to anti-obesity medication. So actually, Andrea, my co-moderator, I've just submitted a paper today looking at the impact of stigma on weight loss drugs. But if you go back almost to the sociology of diagnosis, when you have a diagnosis of a condition such as obesity, whether that's a condition or a disease, it goes two ways. It either legitimizes that condition as worthy of treatment, or it can perpetuate stigma. And the initial research and the pool of literature we've looked at, there are very, very few studies that are looking at the stigma specifically around weight loss medications, but it is coming out that there is stigma because it's perceived exactly what Sanjay said. It's that the drugs are doing the work as opposed to the patients. But I think we also need to acknowledge that in Europe and the UK, we are very different about how we market prescription medications to people, whereas it's different in the States and Canada, where there's more direct consumer marketing. But I think we have to acknowledge the amount of misinformation that's available to everybody and what clinicians and researchers have to deal with when we're dealing with patients and about managing expectations. And if we draw on the literature for metabolic and bariatric surgery, there is stigma, and the stigma is following, what the perceptions are. These are contested interventions. There's no redemption in taking drugs or having surgery. And I think this is where, and unfortunately, the patients are recipient, and this is what the patients are hearing, but this is coming in clinical encounters. But I think we really need to keep an eye on what is happening with stigma as it emerges, as the weight loss drugs are becoming more mainstream. Thank you.
Which is why these events, which are international, are important, because we need, a united front in addressing these events. There's a question that's very interesting. And then after this question, I'll read from the box chat. I would like to pass the word to Marimet again, in case there's anything as a patient she'd like to share, because patients are ultimately the most expert in the field. So the question is, what drives the increase of alcohol, drug use, and other addictive behaviors post-bariatric surgery? Is this related to stigma? And I'm just adding it because there's another question following. If in our country there are any programs that train healthcare professionals to improve obesity care because stigma often begins with the healthcare system itself. So if you guys want to answer these, then I'll pass the ball again to Marie-Matt.
Do you want me to start or the other ones first?
I think for the alcohol drug, it's good if you start, and also Sanjeev, Lisa, if you want to comment on that from a medical health perspective, it would be strong.
What I do know from research done in Norway is that if you do have binge eating disorder and don't get any treatment for that, but go through bariatric surgery, the risk of developing alcohol-related problem increases with 50%, if I'm remembering the numbers correct, but it's a huge risk.
Okay, yes. And Sanjeev, Lisa, do you want to share your perspective about data, why there's this shift and how it happens?
Lisa, did you want to go first, or I can go if you like. Okay, yeah, I mean, I think there's some long-standing data, and Maria Mathieu talked about some of the data that she's heard about and experienced in Norway. I think there's longitudinal studies looking at metabolic and bariatric surgery. Alcohol is very well studied to show kind of increased rates of new onset, or for people at higher risk before surgery, of developing alcohol use problems, particularly beyond 1 year post-surgery. And part of that is related to some physiological changes as well in terms of absorption, but more importantly, metabolism and how there's delayed metabolism. You know, I always educate my patients in our clinic pre-surgery that even if they were social drinkers, like one drink might get them intoxicated in their alcohol level, and it takes longer to clear out of their system as a result of that. And you can think about for people who might be predisposed to alcohol use problems, that this might actually trigger that vicious cycle as a result of physiology. But I think the panelists have also talked about, you know, disordered eating or loss of control or emotional kind of components in relationship with food. And as those things change after, there may be other ways to deal with emotional dysregulation afterwards. And those behaviors could be alcohol, you know, increased shopping, other types of kind of behavioral addictions as well. And although the rates are not as high, I would say, as, you know, that we read about in social media, etc., or historically, they're still higher and need to be something we screen for and pay attention to post-surgery.
I can just add something that I would like to encourage everybody to talk about alcohol and other substances, because when we follow up patients, this is also pre-surgery, of course, but also afterwards, that ask patients, how is it for you with this, with alcohol, for instance? How is it? And don't avoid the conversations about that, because it's so important in many ways to discuss these things. So that was a good question also.
Yes, it's also good to give a safe space to patients for that. I think we have another question if Anja wants to address this.
So Claudio asked if in your countries, are there any programs that train healthcare professionals to improve obesity care? He feels that stigma often begins within the healthcare system itself. So, you know, would people like to give their views on whether such training exists and how effective it is in reducing weight stigma? Sanjeev?
Yeah, I mean, I can speak to maybe two components really briefly. One is in the work that I'm doing with Obesity Canada, we have a training program for healthcare providers called Caliber, which we've offered for people who are in practice, and it's interprofessional. We actually measured not just what they learned and their learning outcomes for several hundreds of people gone through this course. It's a longitudinal course. but it is rooted in weight bias and stigma as the first module and woven through the entire kind of competency framework, which focuses on obesity management. And in that, we demonstrated in a paper under review that showed shifts in weight bias and stigma, both on rating scales, but also through the comments that people submitted as part of the kind of end of course evaluation. So I think those can be moments of doing that. But as I alluded to in my presentation, I really think we have to start in the undergraduate training of health, like our next generation of healthcare providers. We've talked about obesity as a chronic disease, but I don't think we actually teach it very well in most of our training courses. And there are competencies across the world about, what are the obesity relevant competencies that could be easily translated into curricula, in thinking about that, given how much obesity impacts so many other chronic diseases, 250 plus, right? So I think it's a real injustice if we don't do that early on.
Yeah. And I think, Sanjeev, just from my experience with that we have with, we run residential retreats, so we live with our patients.
Yeah.
And I think that one of the important things, if we are going to be running these educational programs or, teaching healthcare professionals, that we do really need to be aware, just reiterating what both you and Lisa said about the internalized stigma, and
Yes.
that we teach our that we understand that, so that we can teach our patients about the internalized stigma, and especially with the introduction or the wider use of the obesity management medications, because as soon as they stop those they start to have some recurrent weight gain, that whole shame cycle starts again. And then what we find with our patients is that internalized stigma is one of the biggest challenges to overcome. So I think when we're teaching healthcare professionals, we also need to reiterate that we've got to address the healthcare professionals' stigma, but also teach our patients tools and strategies to overcome the internalized stigma.
100%. And co-teach it with patients as well, and people with lived experience, which is even more powerful. Yeah.
Well said. I know we're almost at the end, but we still have questions coming, and I think it's good. So if you're fine with sticking with us for a couple more minutes, there's a lot of questions on courses to educate healthcare practitioners in this matter. One has been mentioned in the UK. There's a link for that. I'm not sure if everyone can read it, but it's eqweightytraining.com in case not everyone can read it. I also want to mention, if you feel the need to have a specific course in your country, there's societies, there's national groups, bring it up, organize it, have a masterclass, have a course, because if there's not something, change has to start from the bottom. So if you have a request and a need, bring it up and create an answer, socially, I would say. There's there's also a question for ITCA, if there's any other courses offered in the UK. And ITCA, if you want to answer that directly or in the chat, because we also have a question about whether binge eating or alcohol habit should be an absolute contradiction to surgery, or if there's a way out for it, and one about post-surgery body image and how it might intersect with prior experiences of bodily violence, abuse, or neglect. So ITCA first for the courses in the UK, maybe, and then the others.
I was just going to say, probably in terms of, the IFSO Integrated Health Executive Committee, we've got the Training and Educating Committee led by Julie Peck, that perhaps it would be useful to put a list together of courses available globally rather than just the UK, and make that available. So Andrea and I can take that as an action to feed that back to the exec board on that. But no, I think we should answer the question if there's time. I just had a comment, but please, I think we should answer the questions.
Yes, so I'll read them again for Liz and Sanjeev. So one is whether binge eating or alcohol habit should be an absolute contradiction to surgery. Of course, if ITCA and Ramya wants to share their opinion on that as well. And whether post-surgery body image intersects with prior experiences of bodily violence, abuse, or neglect.
I can speak briefly for, again, based on some of the international guidelines for metabolic and bariatric surgery. I think, alcohol use, when it gets into the problematic use, for sure, those are areas where we pause any kind of further assessment and really address those issues before anyone goes through metabolic and bariatric surgery, given the risks after surgery. So we do use certain screening tools and assessments to have those discussions early, then get people into supports and treatment if they need to, and kind of pause our process. But we also monitor very frequently after surgery as well, because some people don't have problems and develop them afterwards, right? And so that's an important piece. For binge eating, again, I think it depends on severity, because sometimes, at least in the programs I've been involved in Canada, because we have an interprofessional team based approach at many of our centers across the country, the people going through often get education and interventions, even brief, as part of their pre-surgery preparation. And for mild binge eating, sometimes those things improve because people have not had access to any of those supports and benefits. I think if people have moderate to severe binge eating disorder that's untreated, before surgery and go through, that increases the risk of that continuing after surgery. And we know binge eating at 1 year after surgery is a bad predictor of kind of weight loss trajectories and other psychological distress. So I would say it really depends on severity, kind of engagement and improvement in that pre-surgery readiness kind of phase. But as people have more severe symptoms, it is something that we would want to address before surgery. And I don't like using contraindications, because we've shifted to readiness, because some things can be changed with time and intervention. Yeah.
I agree.
Is it okay if I add also something here?
Sure. And then we have the question on post-surgery body image, and then we can quickly wrap up.
Yeah, I just would like to say the importance of the follow-up, because I think it has not worked very well. And we have to develop that and make it better for our patients, so we can support every patient with their challenges throughout the the journey.
So our last question here, before we do wrap this up, is how does post-surgery body image intersect with prior experiences of bodily violence, abuse, or neglect? So that probably needs to be addressed to either you, Sanjeev, or potentially Mary-Mette.
I do can say something. Very often, people take this surgery and both hope and sometimes believe that everything will change to the better. They're not prepared for this gigantic one piece of excess skin. And the skin is kind of echoing the past. So it's still with them, and thing doesn't change. Relationships doesn't necessarily change to the better. You may have a partner who express discomfort over your excess skin. It makes intimacy difficult. So there's no easy way out.
Yeah, and I
Absolutely.
would, yeah, and I would echo that as well, that I think, post-surgery body changes, even at the honeymoon after surgery, people's body images might change for the benefit in themselves, but they get a lot of external comments that might feel foreign or uncomfortable because of past trauma or experiences, if they do have that, right? Sometimes that can, that increased attention can be uncomfortable. And likewise, what Mary-Mette said, the excess skin folds or the longitudinal body image issues can bring up and activate kind of negative thoughts of oneself and self-esteem, and really comes back to the weight bias and stigma that people have experienced through as a result of body image shape and their experiences. So I think it's really, really important to again engage patients in that dialogue ahead of time, that prep them for this, and then follow afterwards to open those discussions because they may not have another avenue to have those discussions.
Thank you. And I know there's still questions coming and comments, but we need to wrap this up. So if you want to contact any of our speakers for further questions, but really thank you for joining this very rich conversation. And I would like to wrap this up by leaving the floor again to Marimet as a patient representative for a final comment on this webinar.
Thank you so much. My message to all of you who engage in us as patients is, there ain't no cure for love. There ain't no cure for obesity. But helping us on the way for a better health, you can make a huge difference whether the experience will be like Stairway to Heaven or Highway to Hell. Remember, meet us as people first. I'm Marimette, living with obesity, but first and foremost, I'm a human being. Meet me as that.
Thank you, Marimet. And that's a very powerful message to end this webinar with. So again, thanks everyone for joining this. Thanks to Marimet as patient representative. Thanks to our speaker. Thanks to the moderators as well, of course. And if there's any other comment.
No, that's great. Thank you just on behalf of IFSO as well. And thank you, Eugenia, for doing a great job of organising this. And thank you for all the attendees as well. And I trust that everybody has learnt a whole lot and is able to leave here with, with a different attitude, I guess. So thank you.
Absolutely. And thanks for everyone joining from different time zones, for staying up or waking up earlier, and for joining this with your questions and comments. Thanks, everyone. We hope you enjoyed, and I think we can wrap it up here.